Is surgery or non-surgical treatment superior in pectus carinatum? Today we will clarify this topic together. Traditionally, parents always want to avoid having their children touched or operated on. Non-surgical treatments are often perceived as being superior to surgical ones. But is there really no situation where surgery has an advantage? Today we will talk exactly about this topic. Of course, the fact that the body is not touched and there is no incision leads families to prefer non-surgical treatments. But non-surgical treatment is not very easy either. There are situations where surgical treatment is actually much easier. To explain, in non-surgical treatment, we place a brace on the chest that creates pressure from the front and back, like this. There is absolutely no pressure from the sides. There are braces on the market similar to scoliosis braces that also include the sides. Surrounding the rib cage 360 degrees would prevent this movement. Look at how my chest expands and contracts. That's why instead of 360 degrees, you only need to apply pressure from the front and back. There needs to be pressure so that I can correct the pigeon chest. The orthosis gets all the force needed for this pressure from the red metal here, and it provides this by taking support from the spine at the back. To prevent this metal from damaging the skin, the force of the metal is transferred onto the bone through a pad. While orthosis treatment provides correction in this way, there is also a minimally invasive surgery for pectus. Again, by using a metal, but this time a biocompatible one, we make small incisions of about 2 or 3 centimeters under each armpit. By creating a tunnel under the muscles and over the bone, we pass this through to the other side, and after passing it, we press it down and fix it to the ribs. In fact, both methods apply the same pressure in principle. What is the advantage of doing this surgically? First, we protect our skin from the pressure of that pad. We apply the pressure directly onto the bone. This way we protect our skin from problems like redness, wounds, and issues related to the nourishment of the skin. Secondly, the body perceives the pectus bar as a foreign object and thinks it needs to encapsulate it. To encapsulate it, the body secretes a fluid in that area. At first, the area around the bar is filled with this fluid, and as the fluid remains, it turns into a gel. It becomes filled with these substances. Later, that gel gradually transforms into a membrane. The membrane then dries and hardens, eventually forming a bone-like tissue. We already wait 3 years for that tissue to ossify, and then when we remove the bar, that bone-like tissue remains there, reducing the risk of recurrence to 0. Meanwhile, this surgery is performed entirely without entering the chest cavity. The inside of the chest cavity is not accessed at all. Pressure is applied from the outside with a bar that is advanced under the muscles. In other words, it's no different from getting braces. It's just that the area is in a slightly more critical location. That's why it's a different treatment from orthosis therapy. We say that orthosis therapy is beneficial up to the age of 17. Why? Because while the epiphyseal plates of the bones are still open, we can press on the bone and allow it to harden in that shape. But with the bar surgery, we can perform it at any age we want. Because a new tissue forms and hardens on the outside, and for those over 17, this becomes the only option. Now let's think about it this way. What kind of advantage does it have in practical life? When you use a brace, you have to wear it even in the heat of summer. The child has to go to school wearing this brace. They may be exposed to peer bullying because of it. They have to struggle with a brace that constantly presses on them while sleeping. It reduces sleep quality. Wearing it all the time damages the skin. But with the bar surgery, there are only 2-3 centimeter lines left here, and the child is freed from it all at once. That's why the Abramson surgery, a brilliant technique defined by Horatio Abramson in 2005, is something we are able to perform successfully here. In this Abramson surgery, we use certain technologies in our own clinic. Those who have followed pectus excavatum before will know. You know that we have a system that lifts the chest wall using a suspension system, that we have created this by combining systems we brought from Korea and the United States, and that it is a unique system in the world. We have integrated this system in such a way that when you reverse it, instead of lifting the chest, it presses down and allows us to apply the ideal pressure to the chest and achieve the best correction under control. After applying this pressure, we screw the butterfly fasteners onto the ends of the bar with our special threaded butterflies. This ensures that the bar does not slip and that the butterflies are positioned correctly. And finally, when we press down and make one last adjustment, it gives us the luxury of being able to tighten the screw. Another innovation we have implemented is using the Pioneer sternal wire. In fact, we call it a cable, not a wire. By using steel cables, we secure these butterflies to the ribs in such a way that they will never move. Do you know what this achieves? In surgeries performed with wires, children can break the wire during heavy lifting or while playing sports if they make a wrong move, which may require another surgery to replace and secure the wire again. But the steel cables we use, these cables never break. We guarantee this, and we offer children the luxury of being able to lift even weights if they want. And of course, just like in pectus excavatum, at the end of the surgery, we perform direct freezing, cryotherapy, on the nerve to eliminate pain, so that the child only experiences a feeling of pressure for 3 days. Other than that, the child undergoes this surgery without any problems and completely pain-free. This is one of the most important innovations we use. Thanks to all of this, I think this surgery is much more comfortable and far superior to orthotic treatment. So, does the surgery have any disadvantages at all? In my opinion, it has only one disadvantage. If this child wants to become a soldier, police officer, commando, special forces member, or, for example, an astronaut in the future, knowing that any surgical scar or having undergone surgery could be a disqualifying factor, seeing these scars during the examination may lead to their elimination. But this is definitely not due to any loss of function or removal of an organ. It's only the presence of a surgical scar that can be an obstacle in these cases. So if the child doesn't have such an aspiration, in my opinion, surgery is definitely superior. When is this surgery performed? Of course, the child needs to reach a certain stage of development. If we place the bar at a young age, as the child grows, an hourglass appearance develops, and this is something we do not want. But there is a process for the child to complete their development, 15 years old and above. They have completed their rapid growth and have had a growth spurt. From this point on, they may continue to grow, but there is no rapid growth. They are not growing 8 or 9 centimeters a year. There are only small incremental growths. That is exactly the ideal time. The bar can be placed at that time. This procedure can be performed at any age above that. There is no specific age limit. When is open surgery needed? We measure the pressure, and if the measurement is above a certain value and we don't believe the bar will be able to press it down, that's when open surgery may be needed. That's why it's beneficial to perform this procedure at as young an age as possible before the chest wall becomes too rigid. I hope this has been helpful. Again, if you have any questions about this topic, also known as the Abramson procedure or minimally invasive pectus carinatum correction, you can write to us with any questions you may have about it. Thank you.